invite the next speaker. It's Dr. Ankur Shrivastava, who will be presenting his talk on biometry, surprises or blunders.
So good afternoon, everyone. I'm Dr. Ankur, Professor of Ophthalmology at AIOS Raipur. And we all in our dreams have target emetropia. We all are, Sir has said, we all are primarily cataract surgeons and running for emetropia. And the essential backbone of cataract surgery is a good biometry. That is a proper IL power calculation. So what we are doing, are we doing biometry giving us surprises, or are we doing blunders and surprising ourselves? So that is what is important required today. I have nothing to disclose financially in this presentation. So what it essentially means is it measuring the various dimensions of each component, its interrelationship, and then using this data to determine the ideal intraocular lens power. It essentially consists of two parameters, that is keratometry and axial length measurements. So keratometer, we have seen different generations, like when we are postgraduates, we have seen this Bosch and Low manual keratometer. We started with this, and now it has moved on to automated keratometer and various topography techniques. So these are the sources in keratometry errors. Most commonly it is the unfocused eye, but nowadays with autokeratometers, these many things have been overcome. What is important is that when to repeat the keratometry. So if the corneal curvature, that is the readings when it comes more than 47 diopters or less than 40 diopter, or there is difference in cylinder more than 1 diopter between the eyes, it's time to repeat your keratometry values. Then the second essential component is the axial length measurement. We have seen various advances in it, started from ultrasound, direct application and immersion, moving on to optical, and finally swab source and intraoperative aberrometry. So an axial length is around 20 to 24 mm. We have been taught that around 1 mm difference in axial length measurement, this results in around 3 diopter change in IL power. So it has a huge impact. Again, the measurement has to be repeated if the difference in axial length in both the eyes is 0.3 mm, or if it is on the myopic side or hypermetropic side, less than 22 mm or more than 26 mm, then yes, repeat the axial length measurements. Now, appellation tonometry more or less has been obsolete. So, but still in some far-flung areas, optical biometer is still a dream, and we would advise them to go for immersion. If not, if you have only appellation tonometer, then these are the some tips for accurate axial length measurement by appellation tonometry. Now, these are certain special scenario when the patient comes with, you have to be careful with your scan and use special methods like inadequate fixation, posterior staphyloma, extremes of the axial length like high myopia or high hypermetropia, macular lesions, vitreous pathologies, dense cataracts, silicon filled eyes, and nowadays more and more patients coming post refractive surgery. So these are the things you have to be careful when you are doing A scans. Never to say there are a lot of advantages of optical biometer, more or less it is an automated system. What we find most importantly is the reproducibility. Every time you repeat the readings and you are getting the same and same readings. So reproducibility is very important in your machine. Even in routine patient, reproduce, if not, calibrate. So these are the different generations of IL power calculation formula, the newer ones like Barrett, Olson, Hill, RBF, and Kane. And these are according to the variables which are used, like 2 variables, 5 variables, 7 variables. And more importantly, nowadays, artificial intelligence has come into play. Hill RBF is based on artificial intelligence based formula. So these are the recommendations for the, depending upon the axial length. Different people have different choices. What I commonly use is less than 22 mm, go for Hoffer Q. Otherwise, Barrett Universal 2 is a universal formula which is truly named so. So in other, you can rely on Barrett Universal 2. A word about A constant that is imprinted on the IOL, and you have to be cautious with this because it's different for optical and ultrasound. Optimize this A constant and you can personalize it for yourself. If you don't want to do that tedious process, go ahead to the ULIV website, you can get that optimized A constant and then use, and believe me, it makes a difference. So these are some of the causes for inaccurate biometry. These are measurement errors, calculation error, transcription errors, and patient factors like dry eyes and irregularities. So how to minimize the biometry? Because many times we leave biometry to our optometrist. So use a better biometry technology, better repeat it and double check it. Now these are common case scenarios which I like to show. In this, the axial length is around 30 mm difference, 0.30 mm difference. It's not much of a difference, and you can see the findings of both eyes, the keratometry, axial length, they correlates, and hence the IOL power correlates. If you go at this eye scan, you can see a huge difference in the IOL power, and when we go back, it is this. That is the axial length, which is much of a difference, and hence repeat biometry, and especially if you have an excess, repeat it with a different instrument. Again, in this patient, you can see the IOL power is coming in 5.5 diopter. If you go for the axial length is not very difficult axial length. So what is causing so much difference in IOL power? That is the keratometry values. So look for this and go in a better way. Repeat the findings. That is what. Now this is another patient. In this, it is extremely long eye. Axial length 31.32 in the left eye and 32.36 in the right eye, and hence the IOL power is coming in -3. So what I would suggest finally is, if you are going for anything extreme, then repeat and repeat before actually implanting and going for an IOL exchange. That really helps you in difficult case scenarios. Thank you all for your kind attention.